Let's get started. Welcome to this Safety 2 Zoom. Today we have Simon Gill and Jonathan O'Reilly, our Q specialists, and in Safety 2. And Simon even convenes the Organization Resilience and Safety 2 Special Interest Group, which I will invite you to join in a second, just once the introductions are done. And they're joined today by Mark Sujan, a co-author of the BMJ Quality and Safety article, The Problem with Making Safety 2 Work in Healthcare. And we also have a couple of real life examples of application from our community. Welcome everyone, and with you, Simon, the word.
Great. Thank you very much. We're all here because we recognize healthcare is a complex adaptive system. There is inherent uncertainty. We're also here because we recognize the promise of Safety 2. The potential is alluring. We can see that it can help us understand what creates safety. I think the opportunity to engage with our teams to understand how they really do the work that they do, and the opportunity to improve safety is something that we all want to capitalize on. I think we're definitely moving beyond the theoretical. Gone are the days when we had conferences where academics would just talk about theories and talk about models and so on. More and more we're beyond the conversation of definitions. We're starting to talk about practical application. I think that the challenge that we have is that our critics of the methodology point to a lack of evidence, and historically there have been a lack of practical applications. So it is something that is the background to which we read the article, The Problem with Making Safety 2 Work in Healthcare. And I think many of us recognize the challenges that were presented by the authors. So we are very fortunate to have Mark Sujan, one of the authors of that report, here today, so that we can start to expand on those issues and talk about the contents. And really, this is an open forum for you to debate. This is not just about us broadcasting. This is about us opening the floor to you all. So please feel free, if you have a question, comment, please feel free to put it in the chat, and we will pick it up as we go. There are about 170 registered for this, so forgive us if we don't get to everyone's comment and question, but we will endeavour to come back to you after this with anything that we can. So what I'd like to do is just hand over to Mark now. I wonder if you could sort of give us an intro, Mark, as to what you see about Safety 2 in practice.
Yeah, thank you, Simon. I'll steal the slides, if I may. Hang on. Right, okay. Welcome, everyone. So my name is Mark Sujan. I work part-time in the NHS at the Healthcare Safety Investigation branch, which is really quite exciting for me because for about 20 odd years, I've been working around the NHS on the periphery, but for about a year now, I'm actually part of the NHS family. So that's really very exciting to see it from the inside. The remainder of my time, I do research and consultancy. So I run my own consultancy company, Human Factors Everywhere. And I work a lot with our professional membership body, the Chartered Institute of Ergonomics and Human Factors. So that's me. And I would like to start with Safety 1, ironically, in a way, because this is not a sales pitch for Safety 2. It's more a critical look to see what is it about this concept and where does it come from? How does it relate to other kind of theories and methods and tools available? And so while there is Safety 2, I would argue there is actually no Safety 1 as such. And I've used this figure here from Neville Stanton and kind of adapted it very slightly. But what we can see is over, about 100 years or so, as systems have changed and become increasingly complex, also the approaches and the thinking around safety has changed. And so, we started off with the kind of scientific management and telling workers precisely what to do, kind of taking the thinking away from workers. And then, over the years, as we introduced more automation, especially, systems became more complex, and therefore novel methods and theories were developed. And so, especially as when an approach, around the turn of the millennium, novel frameworks were developed more on a systems perspective. So we have, for example, resilience engineering, which in many ways is the precursor to safety tool, but which also gave rise to a different type of thinking, Nancy Leveson Stamp, for example. And so I think it's a bit misleading, let's say, or not necessarily helpful, to just group everything that came before into one bag and label it safety one type of thinking. But what we can say is, we are seeing this increasing systems focus, and that systems focus plays out in different ways. And safety two is one way of looking at increasingly complex systems with that systems focus. The other frequent misrepresentation, I think, is that safety one is characterized as being entirely reactive. And so sometimes people say, yeah, safety one is all about, learning from accidents and so on and so forth, or being reactive, coming into play only after something has gone wrong. Again, I think that's not quite accurate, really, because safety one approaches, or lots of the methods for the theories which I presented earlier are actually very proactive in many ways. I mean, you will be familiar, for example, with the FMEA style of proactive risk assessments. I mean, you can actually use these to analyze systems and processes before they have been built. That's the entire purpose, for example, of safety cases, which we see in other industries, like, for example, in the nuclear industry, where you do these risk assessments before even the system goes into operation. Equally, safety one is not just about being reactive in terms of counting the number of incidents. There is a strong tradition of leading safety indicators as well as lagging safety indicators. So, for example, the Health and Safety Executive has guidance on leading and lagging safety indicators. And so the leading indicators are based on, for example, routinely scheduled audits and inspections and so on and so forth to check whether the barriers and safeguards are working as intended. So, what we refer to as safety one is actually both reactive and proactive. But, we can then ask, right, okay, so given all that preamble, why do we need safety two? Well, one thing which these methods which I just described often share in common is that we try to produce representations which lend themselves to be analyzed and used in this kind of fashion. So, for example, here you can see a process which I've represented in the form of a task analysis. And this representation lends itself perfectly for an FMEA style of risk assessment, where we can say, okay, check prescription, for example, as one task step. How could it fail? If it fails, what would be the consequences, and what kind of barriers could be put in place? The problem really is that this, in many ways, in many modern systems, is an oversimplification. And I've kind of mapped the same process, which is administration of an IV drug infusion, using a different notation, the FRAM, functional resonance analysis method. And you don't need to be able to, see the detail, but just, you can see the complexity. There is a lot of connectivity, which we have omitted when we use the task analysis. And so that is really, one of the main drivers behind safety two, that we want to appreciate the complexity of modern systems and that we want to understand the couplings between different parts of the system, between different functions of the systems, and then understand outcomes as emergent outcomes based on these couplings and the variability which is inherent in our systems. And so if we contrast, as Eric Hollnagel has done, from whom I've taken this table here, the kind of safety one type of thinking, bearing in mind there is no safety one as such, and the more recent safety two type of thinking which Eric promotes, then we can say, in a way, he is right. If you look at what came before, they were largely driven by a focus on adverse outcomes. And so safety was defined as the absence of accidents or adverse events, or the absence of unacceptable levels of risk, which is actually a go-to definition of safety. And so, Eric's argument is quite valid, being that you can't really study the absence of something. So we need to find a definition for safety, which we can actually use in studying safety. So it needs to be the presence of something. And so what Eric was saying, it's the presence of some kind of resilience abilities, for lack of better words. So the abilities, I will explain it on the next slide, to adapt and to monitor, to respond and to learn. And from that definition, then also follows the key driver for the safety management principle, which with traditional methods is risk-based. And you can see that also with the HSE model, which I presented on the previous slide about the leading and lagging indicators. That was all about the barriers, the risk controls. Okay, so even the leading indicators are about whether the risk controls are working when inspected. Whereas for safety two, we need a new safety management principle. And here it's about achieving success through performance variability, i.e. through the ability to make trade-offs and adaptations as the system is in operation, rather than just proactively thinking about what could go wrong and what barriers can we put in place. So it's being able to respond to changes and disruptions. Well, not even just disruption, but just changes, because modern systems are open systems, and so the environment imposes changes to which we need to adapt. And then learning from experience takes on a different role. In the past, we were trying to learn from the extraordinary. So of course, that is accidents mostly. And there are lots of now famous accidents, or infamous, it depends how you look at it, like 3 Mile Islands and Chernobyl, Piper Alpha, and so on and so forth, which we always bring up, of course. And they are associated with then changes in thinking really about accidents. Whereas in safety two, we're actually shifting that. And we're saying, let's shift it from learning from the extraordinary towards learning from the ordinary. We need to learn from everyday adaptations and trade-offs to really understand how a system both succeeds and fails. And that kind of puts then the spotlight on performance variability, which in safety two is inevitable and useful. So it's the source of both success and failure. Whereas in more traditional thinking, we are thinking more about systems that we are designing and controlling, and therefore trying to reduce the variability as much as possible, because otherwise we are struggling to control them. And so I mentioned these resilience abilities. So safety as the presence of something. So resilience abilities, or resilience potentials, as Eric refers to these now. And so he's identified 4. Other people have added, further abilities. I think it doesn't really matter, but it's just the shift in perspective. And so that's, the ability to learn, to respond, to monitor, and to anticipate. In the paper, we've kind of contextualized it in a very simplistic way for COVID, for example. So managing patients, during the pandemic, the ability to monitor would be something like, do we know what's going on right now? So for example, do we know how many patients are on the ward who have COVID? What does it mean for the ward in terms of availability of resources? So are we up to date? Are we current with the developing kind of situation? Ability to respond then. Can we respond to any kind of changes? Are we flexible in terms of which resources we can pull in? Can we deploy staff flexibly, for example? Can we deliver services in a flexible manner? The ability to anticipate is more about longer term anticipation. So, how prepared are we for the next wave, for example? That would be a kind of longer term anticipation. And turns out the NHS is quite poor actually at anticipating, as you can see from the recurring winter crisis, which we have every year. And that also links to the ability to learn. So, can we learn from our responses, and can we learn how we adapted and how we can adapt so that, we are ready? Can we also maybe challenge our underlying assumptions and maybe fundamental beliefs? So, for example, what actually constitutes good care in pandemic times? All right. So that was like the kind of preamble, setting the scene. What I would like to do is just illustrate what I've said with a practical example. And so this is taken from, I should say, a research project. So we probably had a bit more resources than people might usually have. But this was about the management of deterioration on a surgical ward. And that is a problem, as you might well be aware. Tools have been developed, such as the National Early Warning Score, which is intended to help people to recognize and manage deterioration, but still it remains one of these stubborn problems. And so what we have done, again, the detail doesn't really matter, is just mapped the management of deterioration on a surgical emergency unit using FAM. And it looks a bit messy like this. And this is not even the entire thing, because that's just one instantiation. You would actually have lots of instantiations. But, that's just the way we did it, to understand a bit the complexity. But what I would like to highlight is, so, the management of deterioration has really been studied, and there has been written about it a lot in the patient safety literature and in the surgical literature as well. And I've just looked at what kind of lessons and learning has been created. And so many failure points have been identified. So for example, the failure to notice that the patient is unwell, or the failure to measure the vital signs, or failure to calculate the news properly, failure to take adequate history, failure to do this, failure to do that. I mean, you get the gist. So people have identified lots of failure points. Okay, what can go wrong? And based on this understanding of what can go wrong, the recommendations often look like this. We need more staff. Staff need to have better training and better education, and they need to apply their education and training. Again, they need to know how to do the news. If they can't calculate it correctly, let's train them in doing it correctly. And the usability of the tools which they use to record the news need to be better. If they can take the history, let's train them to take a better history, and so on and so forth. Again, you can see a pattern here. So it's all about, having more resources, training staff better, telling staff, you should really know better and follow the rules and do things as a procedure. I might be overstating a bit, but, that's a bit the impression which you get from the literature. So it's lots of failure focus, and then kind of barriers to mitigate these failures. So what we tried to do was go a slightly different way with our kind of safety tool hat on. And so based on the FRAM representation, where we try to understand what's the performance variability, how do people manage deterioration on an everyday basis, or as and when it happens, we try to link the identified performance variability to the resilience abilities. Okay, and so what we found was things such as, people kind of start to build an awareness of, what kind of patients might be likely to deteriorate. I mean, someone was saying, I don't even need to see the patient as such. I look at their medical history and I already kind of have the alarm bells ringing. And then I go to the nurse and I alert the nurse and say, you know, if you're a bit worried about that patient, come and find me. Don't wait for them to trigger on the news. But, you know, whenever you're concerned about that patient, come and find me. So you can see a bit how they kind of build in that flexibility and responsiveness there. Equally, in terms of responding, kind of allocating people dynamically was something. One thing also which I found interesting was the notion of dynamic plans. People were saying, currently we have static plans, which means for every patient, we drop a linear pathway, saying this is the patient, this is what they're here for, and this is what's going to be done to them. But actually what we really need would be dynamic plans, which helps junior doctors especially to identify alternative paths which the patient might actually take. And so if this happens, then do this. And maybe even we can bring in people who have a stake in the process, such as intensive care, radiology, upfront in building these dynamic plans, which is all, you know, around enabling us to be more responsive. Anticipating, quite poor, as I mentioned before, and then also learning, you know, about how we do things. Again, it was a surgical environment. It wasn't necessarily great, as you might expect. But so then I would just like then to, as a last point, raise a bit of awareness of the difference in terms of philosophy of recommendations, which we then developed. So if you recall, everything initially was about failures and training people and, you know, having better usability and so on and so forth. But there's, you know, stuff about strengthening these abilities. So having, for example, these dynamic plans, or, you know, specifically including roles that have oversight over what's going on in the department. They already had that to a certain extent. They called this the hot consultant. Also, for example, collaborative decision-making and sharing of tasks, which relates to the relationship between nurses and junior doctors, which is not really well articulated in practice. So, you know, it's quite hierarchical in principle, but actually when junior doctors come in, they're almost a bit afraid and they rely a lot on nurses. But that relationship then changes over time in not necessarily the best of ways. And so maybe that could be addressed a bit more to support the system in being more flexible. But then especially around learning, there are lots of opportunities in which you know, the department could learn more, including this notion of designing resilient procedures. So resilient procedure is different from a current procedure. If you think about news says something like, if the patient has a score of 7, then do this and that. If, you know, they have a score of 2 and 3, then do nothing, whatever. But it's quite static in terms of what it tells you to do. A resilient operating procedure is more like a map in a way. It tells you if you want to get to there, you know, these are different routes you could take. And so they're more flexible, but also a resilient operating procedure is not a document. It's actually a living process which gets reviewed continuously about what kind of adaptations did you need to make or did staff need to make? And what does that mean for our resilient operating procedures? And it's therefore updated also quite regularly. So just that contrast between the types of recommendations generated with the safety tool type of perspective and then the previous failure type of thinking. And so just, you know, to conclude with my own personal reflections. So I find the safety tool perspective incredibly useful to help me understand work as it is done. So the trade-offs and, you know, the underlying tensions and contradictions which people need to manage on an everyday basis. And that, you know, is food for thought. It's definitely great in terms of generating prompts and ideas for interventions. But there is not that kind of simplistic reassurance of, oh, we've identified a risk and here's a risk control which we can put in place. These kind of systems-based interventions tend to be larger, more messy, more controversial because more people have a stake in them. And we all know there is a lot of kind of silos and politics involved. So, you know, it requires a lot more work, and you need to expect a lot more resistance when you want to implement them. The evidence base is actually quite weak for these kind of interventions for a number of reasons. I think most importantly is that we try to evaluate the success of an intervention based on the traditional safety one type of thinking. So did it increase reliability? Did it reduce the number of adverse events? But actually, if you think about it, if safety 2 is the presence of abilities, then maybe we need an evaluation framework that enables us to determine whether the presence of abilities has improved in some way. I always think about it, you know, in terms of almost like a pedagogical setting where you can assess student attainment either by having an exam and giving them 80% or whatever kind of grade, or whether you have something more in depth where you really are able to say something about the skills and the knowledge which they've gained. And I think my last point really is the most important. I don't see necessarily a conflict between safety 2 and safety 1 or whatever you want to call it and other kind of approaches. In fact, I would encourage everyone to maintain a diversity of views. I think safety, whatever definition you want to give it, but ultimately what it relies most upon is the diversity in perspectives, looking at the same thing with different hats on from different perspectives, and in that way building confidence that we are actually moving in the right direction. Right, so thank you very much, and I look forward to hearing all your interesting stories and experiences. And I'll stop sharing now if I can find the right button.
Thank you very much, Mark. Well, yeah, thank you for your insight into this. It's very useful to see it from your perspective. I'm always conscious on your final point, which you emphasize in the paper, is the need for safety 2 to live alongside the traditional safety 1, if you want to call it, but often the underlying principles are in conflict, as you demonstrated. So how can we actually allow these to live together in harmony?
Right, I take it that's a question for me then.
Yes, just a quick question to finalize.
Yeah, well, I mean, I suppose what I try to do is I try to educate people about the different ways of thinking, and you know, I try to say to them, you know, it's perfectly acceptable to seek both risk controls and see how they work, as well as other kind of interventions, because I don't think they are necessarily in conflict. So if you think about the news, for example, news is a fairly static type of thing, but you can embed it in a resilient operating procedure. If you then give people the flexibility to interpret it flexibly, which they do anyway. So I talk to people and they said, well, yeah, we've got patients, and for them, a 7 is actually quite normal. And so we don't do anything. So they already interpret it flexibly. And so it's about raising, of course, awareness that this is what's happening already. So let's just make it a formal practice.
Sure. Thank you. Before we move on to the next section and actually look at some stories and some case studies from the community, does anyone have any questions or comments for Mark on his presentation? Anything from the chat? No. Okay. Well, we will have a chance to come back to this in a moment anyway. So what I'd like to do is just offer the floor to a couple of the members of the community. So first of all, Bianca Vegas from East and North Hertfordshire NHS Trust is going to talk to us about one of the projects she's involved in related to falls. I wonder if you want to jump on now, Bianca.
Hi, thank you, Simon, for inviting me. Hi, everyone. I'm Bianca. Like Simon mentioned, I am one of the safety improvement leads and coaches at Eastern North Hearts, and I manage a whole safety improvement program here. Mark, big thank you to you. A lot of the principles that you've described today resonated our 18-month journey here when we started our falls quality improvement work. And I have to admit, when I started, my approach was very overt. And I was sharing data, stories with staff on the shop floor on our acute medical assessment unit, because that's where the problem had started. And that approach really didn't help. So we've learned a lot of emerging lessons using a quality improvement model for improvement framework to guide us on our journey. So a quick context and background was that we had an increasing number of falls with serious harms happening in our acute medical unit. And we decided that using that data, we'd start some quality improvement work. So the multidisciplinary team and a few of us got together and we started to test some ideas. So one of the initial ideas was that, is the falls assessment process and policy followed? Like everything else, we went down to the ward and started to ask questions to staff about whether this was in place. And we heard everyone say, yes, it's working. We need to have some changes on our falls risk assessment so that it's easy to fill in. And the learning from that, we did apply to, through our plan, do, study, act cycles. However, 4 to 5 months on, we still did not see any improvement in the rate of falls or the reduction in some of the moderate harms that were being reported. So we took a step back and we decided to think differently and out of the box. And we decided to walk that journey with the staff nurse from ED into acute medical assessment unit. And we learned so much, it was exactly how you described it, Mark. Work as done was completely different. And the behaviors, the routines, the patterns and habits that were followed were very different and was not described in a policy. I think sometimes we undermine our staff in their abilities to be creative under pressure. And that came out resonatingly very high. And an example of that was when there were high-risk patients being admitted from the emergency department into the acute unit, the anticipation of risk was so high. And if staffing was low, the ward nurse and the matron would decide that the patient would be put in front of the nursing station so they could keep an eye on the patient. Now, reinforcing that behavior was never done and people just got on with it. And we noticed this happening several times as we, map those processes at various, different points in that improvement work. And for me, really, what we then decided to do was test this idea of reinforcing good learning, the behaviors, the practices that didn't get spoken about at the morning safety huddle, because that was a predefined process already in place. As a result of that, 12 months on, the unit has not had a single serious harms incident. And the reflections of the ward nurse and the staff has been that, they thought it was the fluffy stuff that they didn't talk about and had assumed that staff just knew what to do. So we moved away from what we would have traditionally done using everything that you described in Safety 1, because we spent so much time investigating root causes and telling people what to do. And we went into a Safety 2 approach, and those changes have still been sustained, 18 months on. So I think for me, using the PDSA cycles, but Safety 2 principles has made the big difference in what has led to the success and achieving the aims of the Falls project.
Thank you very much, Bianca. Bianca and I had a chat previously, and it's clear that these lessons are being applied elsewhere in other quality improvement projects, but also beyond. So hopefully we'll be able to come back to this later on, Bianca. But thank you very much for your story.
Yep, thank you.
I wonder if I could just bring in Rob Cunny now, who wants to talk about a project related to learning from excellence. Rob, are you online?
Yeah, thanks. Thanks very much, Simon, and thanks for the invitation to share. So just to give a bit of context, I'm in Children's South Ireland. So we have three acute pediatric hospital sites and two urgent care stroke outpatient units distributed around Dublin. We're in the process of coming together and moving to a big shiny new children's hospital that will be amazing when it is finished. But one of the things that we have been chipping away at over the last couple of years is learning from excellence. And over the past sort of, I suppose, 4 or 5 years, we've brought in learning from excellence at a unit level in our ICUs, our emergency departments, of which we have 3 of them across the city, our operating theatres, and most recently in one of our urgent care centres as well. And then we're working on trying to pull these together to a kind of an overall sort of hospital level learning from excellence program. So I just was going to share sort of 3 vignettes or stories from my experience with this that I think help sort of illustrate how the kind of safety 2 concepts can work in practice. So the first was from our pediatric ICU, and they were one of our pioneers in learning from excellence. A colleague there who trained in Birmingham and who brought this strange concept back with her, and they got the LFE really well embedded in the unit. And I was sitting in on one of their safety and risk huddles, and they were kind of, and what they started to do was they started to share learning from excellence reports at these huddles, as a routine part of it. And a question came up in relation to the scanning system we use for blood samples, and this was in the middle of or the height of COVID. So this was on one level. This was both a laboratory question and an infection control question. And there is my standing there as a laboratory consultant and infection control doctor. And under a sort of, I suppose, a traditional approach, all eyes would have turned to me to say, how do we fix this? But instead, because LFE had helped to sort of generate this much more sort of open sharing of good practice, it was probably the most junior nurse in the group who said, well, hang on a second, we currently go, we take this thing to here, we go to there, and was sort of saying, well, if we just sort of reverse that process. And it was a complete understanding of as work as done, which I would have had no concept of. And by making this very simple change, they were able to fix the problem there and then. And to me, it was a really nice example of tapping into the wisdom of the crowd, of having the sort of psychological safety for somebody to be able to speak up and identify a quick win. The second vignette is from our emergency department, where they brought in learning from excellence, but they linked it in explicitly to a program to support and improve psychological safety. And they used a validated tool and did a number of surveys over time to demonstrate that the level of psychological safety within the unit improved. So they brought in sharing of LFE stories as part of their unit huddle each day. But the other thing that they did was, one of the junior doctors who was involved in this, she created a set of playing cards, and each card has a suggested positive action. So oftentimes, reversing, the question of what's going wrong to asking what's going right. And as part of the daily huddle, they would finish the huddle by somebody randomly going through the cards and picking one of these out and saying, okay, whatever it says in the card, how does that resonate with us right now? And so it was a way of of taking some of these slightly kind of woollier knit your own yogurt, brown rice and sandals kind of concepts of safety too, and making them more real for people. And it was really nice to see how that worked in practice in terms of just stoking up the energy in the room. And then my third vignette is sort of my own slight kind of road to Damascus moment, which was we were looking at central line associated bloodstream infections. We'd done an audit. We were focusing on the wards that are the highest rates, and then realized actually there's one ward with a very high level of central line use, and they've had no infections in 5 years. So we went to them and did an appreciative inquiry approach, and were able to uncover this much more sort of a multidisciplinary continuous improvement culture that they had on that ward. And what we're now trying to do is to take that and see how do we spread that, how do we learn from the positive experience of that ward. And for me, that was a real eye-opening moment. So those are my three vignettes.
Great, thank you very much. That was again a hugely helpful, practical view of how Safety 2 is working within the healthcare domain. What I'd like to do is just jump onto something where you've all contributed input, so that we can actually just review some of these. And what we're going to do is just offer the floor out after we look at your answers. Hopefully we can come back to both Rob and Bianca for further insights as we go through. So the first question we asked was, describe your implementation of Safety 2 principles. Well, of the people that answered, there was more that have said that they've not implemented than have implemented. So we went on to actually ask more detail and say, well, what kinds of problems and issues have you applied Safety 2 to? Now, as you can imagine, there's a hugely wide variety of things. So you can see the things that you would expect in terms of diagnostic process, medication delivery, anesthesia safety. So you can see there are very clear things that have been done. But I wonder whether there's anything from this, Mark, that jumped out at you as any particular trends or anything that you were not expecting to see.
Well, I mean, first of all, it's good to see that it's applied pretty much across the board. What I usually apply to is kind of what I refer to as stubborn problems. So problems which have been studied with previous approaches, but over the years have not really shown any improvement. So for example, management of deterioration. So I can see that on there as well. I've used it, for example, to study handover. Again, handover has been studied for many years, and lots of suggestions around the use of SBAR and other kind of structured communication protocols, which just haven't delivered. So I think that's my guiding principles, but really, yes, you can apply it, of course, to any kind of process or activity.
Great, thank you. So the next thing is we asked the kind of interventions you developed using Safety 2 principles. And you can see learning from excellence was mentioned 3 times, appreciative inquiry was mentioned twice. Both of those have also been mentioned by Professor Rob Cunney as in the last presentation. You can see that there are, again, a wide variety of interventions. So safety huddles, I think, is something we all recognize as a way of intervening in a Safety 2 approach. But it was really nice to hear how that's done slightly differently, and every huddle I've seen has been done slightly differently. But bringing in a practical solution like the cards that were mentioned is a really good way of turning what can be focusing negatively into focusing on something positive. So I guess those were the trends, but again, a variety of interventions evident there. I don't know whether there's anything that jumped out at you on that one, Mark.
Well, there's a question maybe which I have to people who responded. because something which I have observed, and I mentioned it in my presentation, is the resistance which we can sometimes, well, which we can frequently experience when we develop systems-based interventions, i.e. interventions which go beyond the immediate set of stakeholders you'd normally expect. So I was just wondering whether people were able to successfully develop interventions that included, for example, one department where faults happen, but then also other departments, or whether it was really just the immediate team. Anyone want to share some insights?
I can share an insight in that. I'm Rick Roos. I'm from the Haga Teaching Hospital in The Hague, and we did research at the emergency department in how the diagnostic process is gone. And in this research, we observed from the moment the patient arrived at the ED until the patient left the ED. We observed the process, and what we found during these observations was that when a pre-announcement was made, so when a little story was written in the electronic health record from the patients, what they were going to do at the ED, what their medical history was, so a little note what the patient was coming to do at the ED. We saw that when that was made in the electronic health record, that the resident at the emergency department knew better what he had to do. They were more sure about what they did. And when they called the supervisor after 1 hour, when they saw the patient and had the laboratory results and stuff like that, they were more sure that they have done what the supervisor wanted to do. So what we did in our research was we did 3 observation cycles of 10 to 15 patients. And after every cycle, we discussed the results with multiple stakeholders. So for example, 2 internists, 2 medical ED physicians, residents, patient advocates. So we were all together during those co-creation sessions, and we talked about the results of what we found. And after that, we tried to find best practices, and we implemented them on a greater scale on the department. But because we could tell everybody why we wanted to do it, it was more likely that they would apply it, because it was made together. Everyone could give their opinion about it, tell what they wanted to do with it or what they don't want to do with it. So because everyone is involved in the process, it rolled out pretty easily, and everybody is doing it now at the emergency, at the internal medicine department, and we are looking to implement it in the entire hospital. And we will do those co-creation sessions with the stakeholders also with the other departments to make sure that what they are going to write down fits their department, and in that way they can give their opinion about it, so we can make sure that everybody is agreeing with what they are doing, because that's the most important part. I guess you also wanted to know, how did you deal with that resistance? One of the people who was most resistant at the beginning is now our biggest supporter, because it was extra work, and now he thinks because everybody likes to do it and is doing it in their own experience and own voice in what we are doing, helps to implement it on a greater scale.
Right. Thank you very much. And Bianca, I saw you were trying to say something earlier.
Yes, I was. Thanks. Can you hear me now?
Yes.
Okay. Yeah. So I would say everything that Rick has said is exactly what we've experienced. You've turned the late adopters and the laggards into, you've converted them, by collecting data. But if I have a systems view on what you've just asked, Mark, we started in acute medical unit. As we started to map that process, we learned that we had to get ED involved, and then also take the patient through to to the end process, which is on whichever ward they went to. What has impacted what works in one area against the other is the golden thread of communication, the human factors element, the relational factors of how team members work with each other, and then the impact of the sphere of influence. The acute medical unit, I found that the covert approaches worked better. We've been having coaching conversations. What's the hook line that works with the group of team members that works well? what are, psychological factors. And you go from that unit to a ward or into ED, and you have to completely change your approach. So my learning is that, you have to be extremely adaptable, know the environment, the context, and the team players that you're with, and then use safety 2 principles and bring that in slowly, so that you enable them to do what they need to do. They know what they're doing already, and we don't need to tell them that. But as you know, it's quite complex, but I don't know if that answers your question, but we are in that stage where we're starting to share this learning and repeatedly repeating that on various forums till it starts to sink in, and then you take the next step in a covert way.
Great, thank you.
Great, thanks, Bianca. We also asked how you went about evaluating interventions, and actually there's a quite wide variety of ways in which you have evaluated interventions, despite the fact that some of you said it was a bit too early, or you didn't have a way of doing it. But it's clear that there are ways of measuring. You are looking at how you can do it, and you're looking at outcomes. You're looking at, as Mark said, measuring the potentials, measuring actually what is being achieved by this, not necessarily measuring your safety 2, whether you are achieving safety 2 or not, but actually let's look at the outcomes and see how we're getting on against those outcomes. There was, just picking up on the barriers and challenges that you encountered. So this was probably the most widely answered question, focusing on what is challenging, and there were a number of questions related to the proliferation of safety 2 thinking. So you can see there, people are really struggling to battle against safety 1, whereas actually, as we've discussed here, we need to work out a way of bringing these 2 approaches together. And I think it's been said here and in Mark's paper, the idea that actually we don't need to call something safety 2. There are many initiatives that are underway that are not necessarily called safety 2, but they make sense, and they actually start to merge with the safety 1 approaches. Some of the other challenges that you encountered, culture was mentioned a number of times, leadership, resistance to change. Inevitably, there was a question of resources, and that was mentioned 3 times, actually less so than I was expecting, and a lack of capacity. Engagement was mentioned, so engagement from stakeholders being the challenge, and someone picked up on the difficulty of measuring. So I don't know whether there's anything, obviously you've talked about challenges in your paper, Mark, which are reflected here, but does anyone else want to add anything as a final point before we unfortunately approach the end of our session?
Hi, it's Stavros Prinias here. I'm calling well, I'm actually not in Australia at the moment, but I'm an anaesthetist in Australia with an interest in human factors. Can you hear me?
Yes, we can.
I've been a fan of resilience engineering for quite a number of years. And we've instituted a number of interesting adaptations within our department and at our hospital. I mentioned in the chat that we've moved away from just having standard M&M meetings where we actually call them M&M meetings now, where the 3rd M stands for mastery, where we dedicate time to talk about things that we've done well, and we give examples of that. And also during the pandemic, one of the things that became very, very obvious, particularly in the very early stages of the first wave, was that that we put so much stock in efficiency and not enough stock in adaptability, and that meant that we had to completely change the mindset about how we created lines of communication to make to make effective decisions, and how administration, how the executive liaised with the clinicians. And so we had to create these clinical council meetings, which these COVID council meetings, which were meant to be kind of like very frequent team communication briefings, which allowed us to look at what the state of things was from multiple perspectives, to really get down to work as done rather than work as imagined. So we've had a number of these successes. I do wonder, though, whether in fact one of the problems that we're going to encounter is that the relationship between safety, risk, and performance is actually a lot more complex than can be encapsulated by putting things into a safety 1 box or a safety 2 box. That depending upon the nature of the problem that you're trying to solve, a safety 1 approach is possibly very appropriate. And in other situations, it's completely inappropriate. And so rather than looking at these things as being kind of like, oh, people are still persisting with safety 1 thinking, why aren't they thinking like safety 2? Maybe we should be looking at these things more like being different utensils in our kitchen drawer. And sometimes we need to pull out the knife and sometimes we need to pull out the fork.
Horses for courses, as they say.
Exactly.
Yeah, I think that's really clear, and I think that's come out from what we've talked about here and from Mark's paper. I don't know whether there's anything that you wanted to respond to that one, Mark.
No, I mean, just looking at the time, I just want to finish on a positive note rather than on the challenges. So a little anecdote, of course. So just to illustrate how far we've come, because when I first pitched the idea of resilience engineering back in 2008 to the Health Foundation, I was looked at, with consternation and confusion. What is he going on about? And now we have this webinar, which is the second in the series already, and we have groups on safety too and organizational resilience. So the conversations have become much more mature. And I think that's definitely something we can take great comfort in and look forward quite optimistically.
Great, thank you very much, Mark. And I would say, as I mentioned earlier in the conversation, there are a good number of you, in fact, more than half of you, that are not members of Q. So please do have a look and engage with Q. And particularly if you're interested in safety too, there is a special interest group which I convene on organizational resilience and safety too. So please do engage to join, follow us, because we are planning future conversations such as this. So as always, we could definitely spend the rest of the day talking about this, but we must close now. So we thank you very much. We will review the chat to see if there's anything else that we can respond to, but feel free to connect with me or with Mark or with Jonathan on Twitter or LinkedIn and continue the conversation. But thank you very much for your attendance and your comments.